Those of you who are students in Berkeley Public Health may well know Andrew from class. Andrew's a research data analyst and also a lecturer in the online program. And his work is part of the Center for Targeted Machine Learning and Causal Inference in Berkeley Public Health. He'll be talking with us today about drivers of seasonal infant and child growth failure in low resource settings. And so thank you so much, Andrew, for taking this time to share your work with us.
Thank you, everybody, for being here to listen to my talk. I will make a disclaimer at the beginning of this talk that I was at a conference last week and I came down with, I'm not sure if I have COVID or another respiratory infection. So if I mute to cough for a bit, I apologize, but hopefully I'll be able to make it through this talk all right. So today I'm going to talk about a piece of my research for the last and that's seasonality and infant and child health, especially drivers of seasonal infant and child growth failure. So as an outline of what I'm going to talk about today, first, I'm just going to give a background on interactions between health, environment, infections, and malnutrition. Then I'll specifically talk about heavy rainfall and diarrheal disease in South Asia. Then I'm going to talk about individual participant data meta-analysis of seasonal patterns and wasting. And then
Andrew, we're having some trouble with your connection. I'm wondering if you want to try turning your video off. I'm not sure if you can hear me.
individual.
Okay, I think we lost.
Okay, I'm back. Let's try that again.
Okay, sorry. We had trouble hearing you. Yeah, it was freezing.
I'm sorry, that must have been my home internet.
Okay, no worries.
Can you all hear me okay now?
Yes, we can.
Well, great. So I'll give a background on interactions between infections and the environment and malnutrition before so to start on the background, so if you go to low resource settings, you'll see that there's a high prevalence of growth failure of different types. Here's an image from the Bill and Melinda Gates Foundation, one of our founders. In this village, they couldn't find a child who had the height of the average height of children that age around the world. This is known as stunting, where you have a low height for your age. On its own, being short is not an issue at all, but it's a measure of chronic malnutrition that influences long-term health and development. You measure growth failure through looking at Z-scores, which is taking populations from around the world who grew in healthy, nutritional, and infectious disease conditions with sufficient resources to grow healthily. And then you look at that distribution of height and weight by age and sex. So that gives you a normal curve of what you expect a population's growth to look like. And then you can go to a low resource setting like Bangladesh and then see that the entire growth curve of that population looks shifted from that standard healthy Z-score distribution. And then you can look at children below a cutoff for defining measures of growth failure. First, stunting, which is a low height for an age, less than a Z-score of -2. This is a measure of linear growth faltering and reflects chronic undernutrition. In a trial in Bangladesh that I was a part of, I'm going to tell you about in a bit, 41% of the children were stunted at age 2, compared to what you'd expect in a healthy population of 2% who are stunted. Then you have wasting, which is a low weight for height z-score, defined as less than a z-score of -2. There we saw 11% wasting in Bangladesh. And wasting is normally thought of as more of a measure of acute malnutrition. And so the reason we care about wasting and stunting is not any direct impact of being short or being thin for your height, but the fact that they're predictive of higher risk of mortality and are a measure of potential higher risk of long-term poor cognitive development or other long-term health outcomes. And it was found that undernutrition is a contributing factor, not the sole factor, but contributing factor of 45% of deaths in children under 5, with 13% of those deaths attributable to wasting, which accounts to almost 1 million preventable child deaths each year. And the first 1,000 days of life are seen as a critical window to prevent child growth failure, where once you've started on a trajectory beyond this early growth period, it's really hard to catch up to your peers. So if we want to prevent growth failure, we need to intervene early within the first 1,000 days of life. And so there's a large set of drivers and determinants of growth failure, and then growth failure has a large effect on different later health outcomes. Last week, we heard a great talk on food systems and dietary diversity in this seminar series. This is one of the underlying determinants of growth failure. And then there's also a large set that are affected by seasonality that we're going to discuss a bit more today. Those include water and sanitation systems, food handling and preparation, dietary intake and diversity, maternal nutrition, the actual gut nutrient absorption within the child, and the child's immune system. All of these can vary throughout the year. And what we found is that many postnatal interventions have failed to substantially reduce linear growth. This has been found through running randomized controlled trials where you have a control arm and then you give these interventions. And a lot of them do have statistically significant and important effects on reducing child growth, but they don't allow children in low resource settings to grow to the same standard that we expect in a healthy reference curve. So these might include exclusive breastfeeding support with lactational support and exclusive breastfeeding promotion, or giving nutritional supplementation once children stop exclusively breastfeeding, maternal education, and water and sanitation interventions that we'll talk about in just a second. Hygiene, nutrition, and combined wash and nutrition. And one thing we noticed was that the intervention effects on reducing child diarrheal disease from the wash interventions seem to occur mostly by preventing spikes in diarrheal disease during the monsoon season. So the dotted line is the intervention arm, while the solid line in this graph is the diarrhea prevalence within the control arm. You can see around June, July, and both years of follow-up in this trial, there's a spike in diarrheal disease corresponding to the monsoon season, only occurring in the control arm. And that partially motivated my master's thesis, which was on associations between temperature, heavy rainfall, and diarrhea among young children in southern India. So this is a different population from the WASH benefits Bangladesh trial, but in a similar South Asian setting with similar monsoon patterns. And what we saw is that diarrheal disease kind of seemed to track with heavy rainfall events, if you look here in this figure on the left. And you saw this really close correlation between temperature and diarrheal disease. And then if you looked at the increase in weekly mean temperature prior to the diarrheal disease recall period, you saw increasing diarrheal prevalence as temperature increased. And then we also looked at the association between heavy rainfall and diarrheal disease occurring after that heavy rainfall event. And what we saw is, especially 2 and 3 weeks prior to the diarrheal disease recall period, a significant increase in the risk of diarrheal disease. And this was especially prominent if you stratified by long-term 60-day rain trends, where if there was a dry 60-day period prior to that heavy rainfall event, the risk of diarrheal disease was much higher than if it had been wetter beforehand. And then a paper I'm currently on, led by Anna Wen, who's was a former Berkeley student, now at Stanford, just out to review an environmental health perspectives, actually looked at this within the WASH benefits trial and saw that following periods of heavy rainfall, the WASH interventions, this was the combined WASH interventions, reduced diarrhea by 51%, but only 13% when following periods without heavy rainfall. So you both see increased diarrheal disease, and it seems to be a larger impact of WASH interventions in preventing diarrheal disease after this heavy rainfall. And so the implications of this is that heavy rainfall, it's the first event of heavy rainfall that seems to be the biggest risk. And that may be because contamination is built up in the environment, fecal contamination, pathogens that then get flushed into contact with food or hands or directly with mud in the household courtyard environment or their drinking water source, etc. We also saw the temperature may increase diarrheal disease risk through increasing pathogenic diarrheal growth. And it may be this flushing effect of heavy rainfall flushing environmental pathogens into contact with children. And the specific pathway through which the rainfall increases pathogens has implications for interventions. If it's through drinking water, maybe it needs to be chlorine treatment of the drinking water. If it's through muddy hands, then you wouldn't expect the water treatment to do as much as maybe a hygiene intervention or maybe a safe place-based intervention for the child so that they are not as exposed to pathogens in the environment. So that led to my PhD work here at Berkeley in epidemiology under Jack Colford. This was on an individual participant data meta-analysis of longitudinal patterns of wasting, including seasonal patterns in wasting. And this was recently published in Nature. This was a large individual participant data meta-analysis. What I mean by that is instead of a traditional meta-analysis where you're just gathering estimates from individual published papers, we were actually gathering the individual observations, the individual data sets, and then cleaning, combining, harmonizing across all of these different studies. This map on the right shows the location for all of the different studies included in this large data analysis. This was in conjunction with Bill and Melinda Gates Foundation, and they helped us collect and get access to all of these studies. And then among the studies they had aggregated, we used those that measured weight and height between birth and 24 months that were conducted in lower middle income countries that were generally representative of the population, so not enrolling acutely ill children that were sufficiently large enough and that collected repeated measures. So especially for the seasonality analysis, I'm just going to focus on studies measuring children at least monthly so we can see longitudinal patterns in child growth. And so this plot is really overwhelming, but I just want to put it here to show the wealth and disparity in the data. Each row is a different study included in this analysis. Each column is a child age in months, and then they're colored by the number of observations. Repeatedly. But in general, we have repeated measurements from birth to 24 months of age. And what we saw was a highest prevalence of wasting at birth when looking at age-specific wasting prevalence. So remember, that's a measure of acute malnutrition and a weight for height z-score less than -2. So what we did is calculate the wasting prevalence within each study at each age and months. Here I'm showing every 3 months. And then we pool using random effects models, traditionally used in meta-analyses, to get a single estimate across all the cohorts and within different regions, like Sub-Saharan Africa here in blue, Latin America in orange, and South Asia in green. And what you see in South Asia is, though prevalence was highest and at birth across all regions, it's especially high in South Asia. And then after this high birth wasting prevalence, you see a peak again about a year in age. We also, instead of looking at prevalence, when looking at the cumulative incidence and the incidence proportion, which is the proportion of children with a new episode of wasting within a period of time, we see that the highest incidence proportion is still at birth, where the largest proportion of children are experiencing an episode for the first time, or experience an episode within that period at birth. And then you can see by 2 years of age in South Asia, half of children have experienced at least one episode of wasting, and overall, a third of children have ever been wasted. And so we see this high birth wasting, and we actually see a fair amount of recovery from those wasting episodes as measured by weight-filling z-scores above -2. But even among those who are born wasted and recover, we still see a long-term deficit in their growth, where in this top plot, you can see the purple are children born wasted who quickly catch up to their peers most of the way, but never fully catch up in mean weight-filling z-score. And then among those who are born wasted, they, after 6 months of age, they have a higher cumulative incidence of new wasting episodes, higher prevalence of concurrent wasting and stunting, so combines low weight for height and low height for age, which is a strong predictor of mortality risk, and high persistent wasting, which is repeated measurements of wasting. We also see, when not looking at weight-filling z-score over children's age, but by month of the year in the measurement, we see consistent seasonality where, similar to the WASH benefits trial and the South India analysis I showed you, where in South Asia you saw that peak of rainfall around June, July, and then peak in diarrheal disease. Here we see the lowest weight-filling z-scores, the most wasting, around June and July, consistently across all of these South Asian cohorts. And so this might arise from seasonal patterns in food insecurity or patterns in infection like diarrheal disease that I showed you. And the strength of seasonality varies across cohorts, but it's remarkably consistent. And I'll also note the magnitude here on the y-axis. So for some of these studies, there's a full 0.5 to 0.7 z-score units change between the drier season and the monsoon season, which, to put in context, that's 3, 4, 5 times larger than the effect of, say, the nutritional intervention in the WASH benefits trials or other interventions we've tried to reduce wasting. So this is a really large seasonal change in weight-filling z-score. And so then we gathered rainfall data, monthly precipitation data averaged over a 50-kilometer radius around each study, and then plotted that along with the weight-filling z-scores within each of these studies. And what we see is that the weight-filling z-score is lowest, it appears, around time where rainfall is highest. So here in this Bangladesh study, it seems to be the monsoon period. But this is really powerful when we looked across all of these different cohorts, which aren't just in South Asia with a defined monsoon period, but also in sub-Saharan Africa, where you can have multiple rainy seasons within the year, or Latin America, where the seasonality is not quite as pronounced as in South Asia. And then we looked at the weight-filling z-score difference between the 3 driest months within each of these studies, and then before the rainy season, during the peak rainy season, and then after the rainy season. And what we see is consistently lower weight-filling z-score, especially in the peak rainy season, and especially among those cohorts from a high seasonal category. So that's places where the variation in rainfall throughout the year is much higher than other places. So you see this consistent difference in weight-filling z-score between the drier and wetter parts of the year. And the effect is stronger when there is a larger rainfall season within each cohort. And we even see this occurring at birth. So this plot is looking at birth weight-filling z-score by month of the year, with the gray bars showing the rainfall at that time. And this is among all the South Asian cohorts. So you can see that even children's size at birth is influenced by season. And so obviously the rainfall is not directly causing children to have a lower weight for their height, but it's a both marker and driver of different direct causes of this seasonality. So in particular, for low birth weight-filling z-score during the rainy season, that might be because of interuterine growth failure because of worse diet leading up and through the monsoon season, because of worse diversity in diet, less food availability, increased infectious disease like diarrheal disease we showed in the children also occurs in the mothers, as well as malaria in regions where malaria is endemic. And then also there can be seasonal difference in energy expenditure, especially among in rural households where the family is working in agriculture and there's a harvest season. Oftentimes even pregnant women or women with young children might be out helping with the harvest. And so they have higher energy demands combined with the energy demands of pregnancy. And so we saw that the timing of birth affects your birth weight filling Z-score, and it appears that that affects your trajectory over the first 2 years of life. So here we've stratified, there's a lot of colors going on in this plot, but we've stratified by the 3 months of birth and then colored the growth curves over the first years of life by when you were born. And then these gray bars mark the rough timing of the monsoon season in the South Asian cohorts. And what you see is that children born January to March have both a higher birth weight filling Z-score and still see the seasonal fluctuation in weight filling Z-score, but it doesn't appear to be quite, it appears, it happens at an older age because it's occurring in conjunction to these monsoon periods, and the fluctuations don't seem quite as high as, say, someone who's born July to September. And and then when we plot it, so the x-axis is child age in months, then we see that lining it up, some children have a much lower birth weight filling Z-score and a much higher fluctuation across the first years of life, where the age of that fluctuation varies because it times up that they're different ages at these different monsoon seasons. And so backing out to make this a bit simpler, the purple is just the children born January to March, and you can see these smaller fluctuations compared to the yellow line of those born July to September. And we can see that the difference in these is about 3 times larger among those born July to September between this first peak and this first minimum weight filling Z-score down here. So not only is a low birth weight filling Z-score affecting risk of later growth failure, but also that birth weight filling Z-score is both heavily influenced by season and has this complex interaction with season through the first 2 years of a child's life. And so now going beyond seasonal patterns and wasting, I want to put the effects of season within this Bill and Melinda Gates Foundation knowledge integration set of cohorts in context with other causes of child growth failure. This was the second paper I led coming out of this work called The Causes and Consequences of Child Growth Failure in Low Resource Settings, published at the same time in the fall. You can see here on the right, this is a forest plot you'll commonly see in meta-analyses, with each row being a different study we included. And in this paper, we were looking at different risk factors for different measures of growth failure, including wasting and weight filling Z-score, across a large set of risk factors. So here we're looking at sex-specific differences and seeing in general, boys have higher risk of experiencing wasting between 6 and 24 months. It's not the same magnitude across every study, and it's not significant in every study. But then when we pool across the individual study estimates, these black diamonds down here at the bottom, we see a significant, roughly 50% increase in the risk of wasting between 6 and 24 months among boys compared to girls. And I could give a whole another talk about the causes of that, but it has to do with interuterine conditions and immune system differences between boys and girls, as well as potential socioeconomic factors. And so to conduct this analysis, first we estimated a change in population mean Z-score for each risk factor if the entire population's exposure was set to an ideal reference level, or picking in the previous one, the lower risk reference level, they're girls. And so for each exposure, we chose reference levels based on the prior literature, based on, like, say, birth weight categories or food security classifications, or as the category with the highest mean length for age Z-score, weight filling Z-score across cohorts. And then we estimated the population intervention effect within each cohort. And I'm going to pause here and do a little bit of a digression on the parameter of interest we cared about in these papers. Most studies are in epidemiology measure something like a relative risk or an odds ratio, or if it's a continuous outcome, something like an average treatment effect, which is the difference between a population if everyone was exposed versus if nobody was exposed. This black circle here representing full exposure versus no exposure on the right. However, we might not be as interested in, say, rank ordering the effect of each risk factor based on the effect among those exposed compared to those not exposed. But we might be interested in the population level impact of that risk factor. If you're in class with me in 250W or 250B, you know about population attributable fractions and population attributable risks. Here we estimated a population intervention impact, which is a corollary to those population attributable parameters for a continuous outcome, where we're estimating the impact of the if we shifted the observed distribution of an exposure within a population, we're able to shift everyone to that low risk reference level. So a key point is that this effect depends both on the strength of the association as well as the prevalence of the exposure. And I'm going to make a plug for the Center for Targeted Machine Learning and Causal Inference that I'm currently working at UC Berkeley, because we're not going to dive into the details of the methodology, but they allow us to develop estimators that can directly estimate something like a population intervention effect that we care about compared to say, if you're using a logistic regression model and you're stuck with the odds ratio, which may be a parameter of less interest or less utility for your analysis. We're also able to estimate the optimal dynamic treatment rule. And this is if we took everyone's observed level exposure and shifted it to their individual low risk level of exposure, estimated based on other covariates. So this is useful if different children had different risks of growth failure depending on their specific risk factor. And this is not necessarily going to be present for every risk factor. It may be for some things like low birth weight is the high risk level for all children, but for others, like potentially say like birth order, it's not necessarily clear if it's a lower or higher risk to be firstborn or secondborn or thirdborn. And that might depend on something like socioeconomic status of the family or your gender. And so this optimal dynamic treatment rule allows us to see if we've missed any important associations by estimating these population intervention effects where we've set the low risk exposure level. And so we adjust for all other measured risk factors that were not causal intermediates between each exposure and the outcome using targeted maximal machine learning estimation, which I'm not going to get into detail here. If you're really interested, please contact me because this is my other hat at the Center for Targeted Machine Learning. But it allows us to estimate using flexible ensemble machine learning methods that allow for interactions and nonlinearity, et cetera, between our different confounders and allow us to target the specific risk factor we care most about to get a more causal effect estimate. And then we pool these population intervention effect estimates using random effects meta-analyses. And so here's the results of that for weight-length z-score at 24 months. This plot is really overwhelming, so I just want you to be able to see the number of risk factors we looked at from at-birth child characteristics like birth length, gestational age, birth weight, sex, birth order, to postnatal child characteristics like diarrhea and breastfeeding practice, to parental characteristics like age, education, and mother's weight, height, father's education, etc. And then household and environmental characteristics, including wash characteristics, household size, and the season or the amount of rainfall occurring at the time of the measurement. So we're able to include seasonality within this analysis. So zooming out from this really overwhelming plot where we rank ordered all of the different population intervention effects, as well as the individual average treatment effects, we can zoom in on those that were most important for weight-length z-score at 24 months. And maternal nutrition was consistently important across the different outcomes, with maternal weight as well as birth length being the largest drivers of weight-length z-score at 24 months. the rainfall quartile comparing the wettest versus driest seasons was one of the strongest risk factors. And then looking at the optimal dynamic intervention, we can compare the population intervention effect estimated if we set everyone to their ideal exposure level based on estimated from their covariates on the y compared to the static population intervention effect on the x-axis. And what we see here when examining rainfall quartile is the intervention effect is actually a little bit higher when we use this optimal dynamic treatment rule. So that implies that for some children, maybe the pre-monsoon season is a higher risk factor. And this could depend both on like the specific study as well as the specific characteristics of the children. So it may be for some children, the biggest driver of seasonal wasting is peaks of infectious disease like diarrheal disease, or other infectious illnesses during the peak rainy season. For others who maybe come from a more food insecure household, maybe the biggest driver of wasting is increasing food prices leading into the monsoon season during the harvest season. So there can be a complex timing of seasonal wasting and drivers of it that the optimal dynamic treatment rule allows us to start exploring a bit. And so some lessons from this work is this was a really large, long-term, I spared you the details of the many, many hours I spent on data cleaning and merging and checking and harmonization, but it's this really unique opportunity to identify novel patterns across combinations of time, space, and human characteristics that weren't necessarily possible in any of the individual data sets. However, we weren't able to just get all of this data from the Gates Foundation and throw it into a machine learning model and suddenly have novel scientific insights. It took a great effort to clean and understand the data. There were still issues with sparse data, especially at specific ages and specific regions and for rarer outcomes like more severe forms of growth failure. And we had to coarsen the data to be able to standardize measurements and risk factor codings across studies. And so it might be helpful for future studies to have sort of a standardized data dictionary that, say, uses a standard food security metric or something like that, that makes it easier to conduct the study you care about, but then share that data with other researchers who are going to conduct different types of analyses. And I just want to take a moment at this point to highlight the importance of team science, where I'm presenting on this result, but we had about 30 co-authors on these papers, and then I think close to 100 group authors who were helped review the papers and were researchers on the studies contributing to this analysis, who gave valuable insight both into how we should conduct these analyses as well as understanding the context that their data came from. So this is a really important team science between epidemiologists, nutritionists, and biostatisticians. Some of the data contributors I think are listening in today, so thank you. And so the implications of this work is that characteristics most strongly associated with wasting and stunting were measured at birth, which suggests very early origins and reinforces a focus on prenatal interventions for prevention, or maybe even preconception interventions where women of childbearing age are given, say, nutritional support or, say, monitored for seasonal growth failure. The characteristics that we found that were associated with wasting were not easily modifiable. Things like maternal height or age or season is not modifiable, but they're useful for screening children at high risk of wasting. And then I didn't show these results, but we found that even though there was high recovery from early growth faltering, it was a strong risk factor for more severe later measures of growth failure and mortality. And so the traditional conception of the early origins of adult disease focuses on the first 1,000 days. But maybe as a result of this work, we should refocus. We shouldn't ignore children older than 6 months, but it refocuses attention to if there are additional prenatal, preconception, and early childhood interventions we can give to prevent this early onset of wasting, as opposed to dealing with treating wasting in older children, though we still need the treatment programs alongside any potential preventative interventions. So now moving from these large individual participant data meta-analyses of observational analyses of seasonal patterns and wasting and causes of child growth failure, I want to take a moment to talk about an individual participant data meta-analysis I led on the effect of randomized controlled trials of WASH on pathogens in the environment. So far, in looking at the causal chain leading up to diarrheal disease and child growth failure, we first focused on WASH interventions, effect on symptomatic diarrhea in the WASH benefits trial, as well as child growth. And then we looked at the effect of season as well as household and parental risk factors on symptomatic diarrhea and in the South Asia heavy rainfall analysis, and on child growth through the Bill and Melinda Gates Foundation knowledge integration analysis. And then we also looked at household and parental risk factors on child growth within the knowledge integration analysis. However, we're interested in looking at each step of the causal chain from WASH interventions to the environmental contamination that at the beginning of the talk I mentioned might be what's getting flushed out by these heavy rainfall events on child enteric infections, leading to symptomatic diarrhea and poor child growth. So as part of the Lancet Commission of WASH, I conducted an individual participant data meta-analysis of pathogens on the environment. This included WASH trials measuring both child health as well as environmental measures of either pathogens or microbial source tracking markers. These are genetic markers of the origins of fecal contamination. It can tell you if it's human or from a chicken or from a cow or from a dog, et cetera. And our first aim was to see if WASH interventions effectively reduced environmental contamination, and if they specifically reduced it specific pathogens or microbial source trackers in specific sample types. And then we wanted to know if environmental contamination was associated with infection, diarrheal disease, and growth. And the first of those aims was published in Lancet Planetary Health, and the second one is in review at Lancet Global Health right now. And so we found that generally within each of these WASH studies, there was a relatively rare prevalence of specific pathogens and specific within specific sample types across each of these individual studies. So this plot is showing the effects of the WASH interventions on any identified pathogen in any sample type. So that's child hands, soil, water, flies trapped in the kitchen. And you can see that there's a very small but significant reduction in the prevalence of any type of pathogen in any sample type when given any of the WASH interventions across all of these trials. And this is including WASH benefits, Kenya and Bangladesh. And then we saw that when you stratified by the season of measurement, that it was not significant, but there appeared to be a slightly more protective effect of the intervention on reducing environmental contamination during the wet season. Then we looked at associations between any pathogen measured at any sample type, first, and height for age z-score at 6 months. So this is a measure of stunting. We saw a small but significant reduction in child height for age z-score if they had been in a household with any pathogen type detected at any sample type previously. And then we saw an insignificant but slight increase in risk of diarrheal disease after detecting any pathogen in any sample type in the environment. However, we saw a significant prevalence difference in increased diarrheal disease during the wet, if the diarrheal disease and pathogens were measured during the wet season. So in sum, there weren't that many WASH trials in this study, and most of the analyses of specific pathogens and MST markers in specific sample types were null or inconsistent or had too small of a sample size. And we saw little environmental effect of the sanitation interventions, small reduction in pathogen presence in the environment. We didn't see any effect on MST markers. And we saw that pathogen detection in the environment was associated with an increased risk of pathogen-specific infections. I didn't show you those results. Small linear growth deficits, and then a small association with symptomatic diarrhea, but only in the wet season. And we didn't see any association with MST detection. And so the findings of this study weren't strong, but reinforced the causal chain, especially around the effect of WASH interventions on reducing seasonal wet season contamination in the environment, and then the effect of that wet season contamination on child health. And because we saw small effects of these WASH trials, both on environmental contamination and in the main trials on child health, this indicates a need for more comprehensive WASH solutions. And I want to turn to questions really quickly, but first I'm excited about the next step of this work. So I just want to make a really quick note that I'm working on an analysis called the International Milk Composition Consortium. And this has both longitudinal measures of child growth across 4 different cohorts and trials, as well as a bunch of different measures of different macro, micro nutrients within breast milk, as well as proteomics and oligosaccharides and microbiome. And so we're able to look at how composition of breast milk changes over the season and if that influences child growth. And then I'm also starting to plan out a project on looking at seasonal predictions of micronutrient deficiency with the Micronutrient Forum. And this analysis is just getting started, but with some very simple analyses, we're seeing a significant seasonality in more of these thousands of breast milk markers than you'd expect from type 1 error alone, with 2 of these plotted here. So it does appear that there is some seasonality in breast milk composition, and I'm really interested to see how that drives seasonality in child growth. So in summary, heavy rainfall was associated with child diarrheal disease, especially after dry periods. WASH interventions in Bangladesh seem to reduce diarrhea primarily through reducing seasonal peaks in diarrheal disease. We saw strong seasonality in child wasting, even at birth, and these affected growth trajectories through the first 2 years of life. And we saw that early wasting was high, and even with recovery from early childhood wasting, it had long-term effects on health and increased risk of mortality. And that there was some weak evidence that WASH interventions reduced environmental pathogens more during the wet season, and that the environmental pathogens were more associated with diarrheal disease during that wet season. So maybe the WASH interventions are, say, keeping the environment a bit cleaner, and then during the wet season, heavy rainfall, say, if you have inadequate sanitation, flushes fecal contamination out into the environment, and so it's able to move more freely with heavy rainfall, and that flushes into contact with children or the drinking water or food, etc. So strong chain of evidence on seasonal drivers of child growth failure, which leads to an opportunity to develop seasonal interventions to prevent wasting, especially because we saw the seasonal fluctuation is larger than any effect we've seen in preventative trials trying to prevent wasting. We also have a need for more and more comprehensive prenatal and preconception interventions, as well as targeted postnatal interventions, both for children who are wasted, as well as potentially seasonal interventions, and more comprehensive WASH solutions, as well as further research in examining the causes and heterogeneity in the seasonal malnutrition, either through breast milk or specific environmental pathways, or the specific infection disease drivers using other data sets. So with that, thank you so much for listening to this talk, and I'd like to turn to questions. And I'd also like to thank all of the data contributors for all of the studies I presented today. I was able to do a lot of secondary data analyses because of the generosity and intellectual contributions of all of the data contributors.
Great. Thank you so much, Andrew, for that great presentation. It's amazing. Amazing amount of data that you have reviewed with us. So thank you so much. Let's open it up to questions. If people want to add questions in the chat, or I see Tulika has a question. Do you want to go ahead? And then Leah?
Sure. Hi, this is Tulika. I was curious if you emphasize the need for greater WASH and more comprehensive WASH interventions, but how much of your data, for example, could be, or analyses could be used to point towards requiring more like infrastructure within communities, such as as your images might also sort of support that in terms of like requiring better roads or actually like a plumbing system. Can that be used to support those infrastructure needs?
So that's a great question. And we sort of have this gap of knowledge in randomized trials or in the evidence where we know large-scale wash transformations work in improving health, especially infectious diseases. So like building sewers in London led to both a massive reduction in mortality and enteric infectious diseases, and improved the average height of London through the 19th century. All of these interventions were, compared to that, small scale, delivered at the household or compound level, and weren't involving pipe sanitation or piped water, or the large scale infrastructure transformations you're talking about. So there has to be some level where we go from these smaller scale wash interventions that aren't making large improvements in child health to what we know happens with high quality piped water and sanitation in high income countries. And then the question is, in resource limited settings, what is that intervention that works?
Gotcha. Okay, thank you.
Leah?
Yeah, I just want to say congratulations. Like, what an incredible production and what an incredible amount of work, Andrew. So you and your team, it's really phenomenal and adds a lot to the literature. My question is, okay, so I'm thinking about, you're saying really we have to do something during the pregnancy period to reduce low birth weight. And then I'm thinking, actually, low birth weight, in a way, you can't promote having greater birth weight unless you also are investing in medical systems that allow women to give birth in safe capacity. Because a lot of times people are, pregnant people are making a decision possibly to eat less because they don't want to have a big baby because they're afraid of dying in childbirth. And that's like a very real concern. So I'm just curious, like, if there's some way that you could, or like, maybe I just want to hear your thoughts on the ethics of trying to push for more birth weight interventions without necessarily investing in the like systems that would allow it to be safe for women to have bigger babies.
That's an excellent question, and it gets at, I both want to like advocate for interventions that we can do now that are successful, while part of this is this intergenerational effect of malnutrition, where we saw that the strongest risk factor for both stunting and wasting at birth and then in older children was just maternal anthropometry. Some of that is just a general measure of like the family socioeconomic status. And even though we're adjusting for all measured confounding, including household wealth, we're not adjusting for everything. But there's also like the direct effect of maternal size. Whereas you said, like smaller mothers with a larger baby might be more afraid of dying in childbirth, or there's just interuterine growth restriction among smaller mothers, or their size is a reflection of malnutrition leading to poor fetal growth. So it might be something where when I say preconception intervention, maybe that preconception intervention is actually the infant interventions that 18 years later, 20 years later, are improving the health of the next baby. To answer your question about how to push for higher birth weight without, say, affecting maternal mortality, I do not know the answer for that. That's a great point, and gets at that we know transformative changes in the healthcare systems, the wash conditions, the nutritional environment, and socioeconomic development can improve these health conditions. And I don't know the answer to what specific levers we can pull in absence of that.
Thank you. Thanks a lot.
Great, thank you. Any other questions? I know we're almost at time. Jay has a question. Did you find that children born in certain months just after the wet season experience less wasting than those born in other months?
So it depended cohort to cohort, but in general, the highest weight filling Z-score overall was during the driest season. Let me pull up the birth plot. So here we see the highest weight filling Z-score. This is pooled over about 12 different cohorts. So it might depend if you look individually at each cohort, but was in this really, yeah, the post-monsoon period, December and January. So it did appear to be not just highest during all the dry months, but specifically after the monsoon season. And I'm not quite sure of the explanation for that. Maybe specific timing of food pricing, the infectious disease environment, and this interplay between timing of birth, how we see age-specific patterns, and low weight fluency score, and how that interplays with this seasonal effect. So I'd really like to do more research to untangle those pieces.
Great. Well, thank you so much. We're at time, but thanks for sharing your work. It's really fantastic. And thanks everyone for joining. Really appreciate it. And have a great day, everybody. Thank you.
Thank you, everyone, for coming to listen to me.
Thanks. Bye-bye.